cool thing happened today. We got delivered 3 of the new Airway Mannequins that we just bought. If you don't recall, Aaron and I and Kyle got to go down to the EMS Expo in Vegas. And while Aaron was wandering around the expo hall, he stumbled across these new mannequins. Got a grant. We were able to buy one for each of the 3 stations. We kind of did that on purpose because we wanted for you guys to not have to kind of go from station to station and jump around into all the training equipment, trying to find, you know, the right adjuncts and back valve mask and who's got the mannequin, etc. So it's awesome. They're great mannequins. Brandon, why don't you come tear into it and we'll talk a little bit about it. I wanted to do this because there's some unique features. This is not like the HAL mannequins that we've had before. It allows us actually to do a lot of really cool stuff with our airways. But they also require that they get set up right. So I'm going to talk a little bit about the user's manual. It comes out of the box. If you haven't already seen, they're all wrapped up. But a couple things in them that I want to talk about, and then there's the new mannequin. So we'll get this out of the way. The cool thing about the mannequin is it allows us to do literally every single thing that we do for airway management to practice it, but also to simulate some kind of more difficult airway scenarios. So we probably ought to talk about some of the features of it, right?
Let's do that.
So Nate, if you come up here, you'll notice that it doesn't have teeth that break like the HAL mannequin that we're used to, but there's clearly teeth in there. We can nasally intubate it. We can put NPAs in it. In fact, Sean's going to show us here how some of the things work. Pretty real to life. It's been pretty cool to tinker around with. Orally intubate, video laryngoscopy, all of our supraglottics, etc. I'll show you here in just a minute, but these necks are replaceable. And we can actually have the neck that we just have in here now that it comes with kind of by default, which is the one that we ventilate through. And then it's also got some accessories that we can do surgical crike with, which is super cool. So you'll notice that there's kind of, for lack of a better term, a little bit of a cage in there that each of these different airway trachea devices fit into. So we have the one that comes with it, which is just the normal ventilation one that the skin's on. It just drops in there and you can easily see how that goes in. This one is the one that we can do crikes on. The cool part about this is it's got several trach pieces that we can replace after we've done it a few times. It comes with its own cage, for lack of a better term. This just drops in, and you can see there's actually ridges and everything in there. It fits quite nicely, and you'll know exactly that you're in the right place. It just drops in the center, just like the other one does. There's skins that go across it, so you would just lay the skin, but before you do that, in each one of these accessory boxes is also some papers that you'll be able to tell are shaped just like the cage that you put across it, and they are the cricothyroid membrane. Then you'll lay over the top of it the skin, and we can then do surgical crike. And once you do the surgical crike on it, you can insert the tube, you can insert the bougie, doing the bougie crike method that we prefer to use, and you can ventilate it just like you would in a real crike patient. So the only thing we can't simulate it with it is the blood. So that's kind of the different airways. Nate, if you want to poke in here. Aaron, when he got the grant, made sure that we got this accessory pack that's got plenty of the crike membranes, it's got plenty of skins, and it's got plenty of extra tracheas. Now, I will point this cage out. This cage is actually designed, because they use these in medical schools and stuff, this cage is actually used to do not a surgical crike with, but a trach with. So in other words, this plastic piece right here, they would simulate doing a trach with. I don't know why we would ever use this. We're not going to use it to simulate surgical crike. It's in here. You can definitely put it in, but it's not going to give you anything that you won't get already from the surgical crike one or just the normal airway ventilator. So probably the coolest thing about this mannequin, other than all that it allows us to do up there, is what it does back here, kind of the guts of it, for lack of a better term. This thing, while it might look to be electronic, is actually all pneumatic. It operates off of an air fiddle. So when you get these brand new, what you need to do is fill, and I'm going to show you up in here, Nate. Underneath here are 2 big white airway reservoirs that sit underneath where the lungs are. And what Brandon's doing right now is filling up these reservoirs with air so that it can activate the features of it. So when you get this out, if you're the first one that happens to use it, or when you're filling it, there's this little switch here which allows the air to release, which is what you're supposed to do when it's not in use. It says release air underneath here. When you're filling it and when you're operating it, there's a hold position. And what the instructions tell us is that we want to try to inflate this up to 3 psi. And while it certainly goes around to 15, never do that, okay? The instructions are pretty explicit that it only needs to go up to 3. And it's actually...
That's because it only goes to 3.
It's pretty hard to do. Ralph, Brandon, everybody's tried to get it above 3, and it's pretty hard. But the cool part is now, is based on how we flip these switches, or how we operate the lungs, we can now simulate a bunch of patient situations that we don't routinely come across, which means we don't routinely train, but are pretty cool. The first one is tongue edema, and we'll show you here in just a second what that looks like. But when we flip this switch, that air flows up to the tongue and inflates the tongue and makes it nearly an airway obstruction. It's certainly difficult to pass. The next one is pharyngeal swelling. When you flip that one up, the posterior part of the airway swells up, and it's going to make tube delivery and blade insertion and OPA and even supraglottic airway insertion more difficult. The next one is laryngospasm, and I think this one's super cool. Sean's going to show us here in just a minute, but this actually closes the cords right down to almost to the point where all you can fit through it is basically a bougie, which is going to be awesome for us to simulate because we don't get to do this very often. Last one is pneumothorax, and what this does is it isolates a lung so that when you're bagging or when you've intubated, it'll only inflate one of the lungs, so you can clearly tell the difference between which has got a pneumo and which one doesn't. The two up here are your right and left lungs, and all it does is turn the lung off or on, off or on. What that does now is when you're bagging, you'll only, if this is off, you're only going to get chest rise out of the left side. Or if this one's off, you're only going to get chest rise out of the right side. Or if you disable both of them, basically it blocks airflow into there, and it's going to simulate somebody that's probably got like a tension pneumothorax that's going to be very hard to bag. And so the cool part about that is, knowing that somebody's got a pneumothorax, we've actually got the ability to needle them. So I'm going to flip these off. Remind everybody again, it's not electric. There's no charging cords. There's nothing we're going to lose. All we have to do is keep track of the bulb thing that comes with it. However, the nice part is, knowing that firemen are who they are and that we tend to lose stuff, you can also put a bag valve mask on and use the bag valve mask to inflate it with too. But let's try not to use the bulb that came with it. That would be a good idea.
Also with chest rise and fall and all the accessories up here, we can simulate gastric tension. The stomach will rise. If we position these correctly, we can simulate air going into the abdomen.
So Nate, I'm going to have you come up here and we'll show off a couple things about the chest. So the rib cage is free floating, okay? It is also a CPR mannequin, so just so you know, there's a plate, a metal plate underneath the lungs and a spring, and it gives us the recoil that we would find in chest compressions. What I don't want you to do is put an autopulse on it, all right? Don't put a weight distributing band across this from the autopulse. Anyway, the ribs, you'll notice on the ribs up here in the second intercostal space on both sides is a little tube. And what you can do is palpate underneath here, feel the intercostal space, and I'm not gonna lie to you, it's a little bit of a challenge, but you can feel that, and what it allows us to do is a needle thoracotomy on both sides. The cool part about this is all we have to do is pull these out from underneath here. They're replaceable, so once we've needled them, then all you got to do is there's replacement parts. You take this little black collar off, slide a new one on, put the new collar on, and we're back to the races. And so it's pretty cool. It's a nice option that we can do.
Some spit for that.
Yeah, it does need a little bit of spit. Additionally, underneath here, both lungs, you can tell that they inflate nicely. So when we bag, you'll get nice even lung distribution in there. Now they're going to overinflate because they don't have the chest, but those will inflate nicely. There's the spring I was telling you about. It's the CPR recoil. And so this foam piece, when we originally pulled it out, I was mistakenly thought that it needed to come out. It doesn't. It stays in there. It simulates your abdominal contents and the diaphragm. So keep all this stuff in here just as it goes. There's nothing you'll need to set up new out of the box, and drop the chest wall back on it, and we'll show off how it works. So, Sean.
Yeah. All right, so just kind of going over some of our airway adjuncts. Although it's not necessarily airway training, just so you get familiar with what we can use inside this gun. So starting with some of the basic airway adjuncts, obviously our OPA or oropharyngeal airway. This mannequin will take it just fine, just, you know, whatever method is that you've been taught or you're comfortable with by policies and that. Just go ahead and use those as you would. So we're going to demonstrate having the patient super plugged. We have an OPA in place. We can also drop NPAs as well. So you're going to feel as you do this, the anatomy is actually quite realistic. As you're doing this, you're going to feel the resistance from that. So make sure you use some of the oil that comes with it to be able to lube it up. So you'll see as we do it, like I said, it's pretty realistic as we drop that in. This one probably may need just a tiny bit more lube on it. But anyway, so we'll drop that in. This other one, a little bit more lubed. Put this in as well. Remember, as you do this, you're going straight down rather than back, just like what you would do on a patient. So you get those in place, and it'll take them just fine. Like I said, this one needs a little bit more lube in place for it. But so all your basic airway adjuncts, it takes without a problem, no problem at all. So going over some of the other adjuncts that we have, you do have to be a little bit mindful about some of the sizes that we have. So for instance, let's maybe we'll start with some video laryngoscopy. So with intubation, a 7 or a 7.5 is the tube that you want to use. Don't go 8. Don't go bigger than the 7.5. Also, once we get to the bougie and that, you'll see that it might be better to even use one of the smaller tubes. We'll go over that here in a moment. So I'll just demonstrate dropping in using video laryngoscopy.
Hold that so Nate can see it too.
Excellent. So, drop this in here. Back it out just a little bit and stay left.
I noticed that the anatomy is actually pretty different from the Laerdal mannequin. I think it's awesome because I think all of us get really used to looking in that Laerdal mannequin and what it looks like and how it feels, and it'll be nice to have something different to use. So
DL, it'll take the Miller or the Mac just fine. The Miller, you don't want to go bigger than a 4. A Mac, you don't want to go bigger than a 3. So we'll demonstrate both. Awesome, thank you. So the direct laryngoscopy, same thing with that. Like I said, the Miller works just fine. As you can see that okay, Nate? It's actually very easy to intubate this mannequin. So we have, that's the Mac, like I was saying. So the Miller, same thing, works just fine with this mannequin. Just remember not to add any trauma to the mannequin. Be careful, gentle as you go through it all. But it intubates very easily, very easily. So that's our intubation equipment. We can also throw in the bougie. In fact, let's do this. We'll drop the bougie with doing some of the pharyngeal spasms.
So Nate, why don't we show everybody real quick. Why don't you go in and get a view of the cords real quick, Sean?
I can't see the screen, so let me
So
know.
there's a nice view of the cords for Sean. Now we're going to flip the switch and show everybody. That's what happens when we do laryngospasm. So this is a circumstance where we would want to use a bougie when that happens. So we're going to have Sean.
That in there.
Now pull that out and show everybody what it looks like on the device. So you can see that's super tight in there.
So, like I was saying with the 7.5, with this laryngospasm, it's very hard to drop a 7.5 through. So using a 6.5 works great with this mannequin. So you'll put that on there. And if you can see that screen, I'll drop that a little bit more in there. Kind of see you can maneuver it in there a little bit better. So there's that.
Sean, what would happen if you push that 6.5 tube in too far?
So you can write main stem on this mannequin, which is a pretty neat feature. We can demonstrate that here for you as well.
So leave it where it's...
All right, so we'll go ahead and advance it all the way in as to show a right main stem. And then you'll see we're just ventilating that right side. So it's kind of nice to be able to train with that, be able to know right where your placement is so you can get that right. Now to move on a little bit more with our supraglottic airways. So we have the ILMA that we have, which is one of our backup tools we can go with. So just going through all the proper placement and that with it, it'll take a 4 without any problems. So we drop that. We also have our tube we'll throw in. And then obviously we're going to inflate the bulbs. So with that done, you'll see as we bag, you'll still have pretty good compliance and chest rise and fall with that as well. So the LMAs are a go. They're a great way to go with it. If you wanted to practice with the King Airways, then that's also something that we can go with, and we'll go over that.
Let's real quick, Nate, we'll show everybody. I'm going to have Sean drop the glide back in. We'll try and demonstrate a couple of the other features in the airway when we use the pneumatics. So just pull that out. So we already saw the tongue, but I'm going to have him drop the King in and show you what the tongue looks like when it swells. So just kind of real superficial. If you can get, I don't think we're even going to be able to get the tongue. Point it to the back of the airway down over here. Everybody watch, actually Sean, come right there. Everybody watch this area. This is actually the pharyngeal swelling. So I don't know if you'll be able to see it, but there's an air pocket right there in the back part of the airway, the posterior part of the airway, that swells. So what that's going to do is cause difficult tube delivery. It's going to cause difficulty in getting maybe a regular sized ET tube in there. It's going to be difficult getting an OPA in there. So let me just highlight one thing. We're designing these airway situations on purpose, but that doesn't mean the way that we overcome it is brute force and tear up the mannequin. Again, they're $2,500 a pop. We were really lucky to get them. Let's try to take good care of them, but still use the features. So it's about being delicate. It's about overcoming. It's about better airway positioning. It's about using a jaw thrust to overcome that swelling and using a good airway partner. So that's the first one. So pull that back. We showed everybody, but real quickly, we'll show it again. Drop it in there again. We'll show everybody exactly what those chords look like when they swell. So there's normal chords, and that's a good view. That's what we would normally get. There's what you're going to see when you get laryngospasm. So again, you want to use a bougie, smaller tube. One of the things that we did do was we inflated all three. So even from that picture, you can see that the pharyngeal edema swelling pops up underneath there. And a little tiny bit, you'll see the tongue swelling. It pushed the blade down. I'll deflate it, and you could watch the blade actually get pushed down because of the swelling. Try this, because what you'll find is this is super difficult to bag. And it's going to require you to do 2 thumbs down, jaw thrust, 2-person bagging, and really overcoming that increased airway pressure. So, great mannequin, great tool. You should use it frequently in your training around the station. And the last thing I would say is, once you've pulled it out, you've used it, you've gotten used to the features and how it operates and stuff, don't do your airway training here. Don't do your airway training here on the floor. Take this mannequin into one of the bedrooms and put it in, put it in Jeremy's bed and intubate in there. Put it in the driver's seat of the ambulance and practice, put it on the gurney in the back of the rig and practice doing the head up and proper airway positioning, and get suction out and put it under the right shoulder and practice it in the environment that we actually do it instead of here on a table, which is where we're never going to do it. Anyway, great tool. Lots of props to Aaron to working on both the grant and getting this all put together. It's going to make what is, to me, in my opinion, good airway training that we have, great airway training. So get them out, use them, tinker with them, play them. Any feedback, concerns, questions you've got, get with me on them. But otherwise, thanks, you guys. Appreciate your help. Thanks, you guys. Take care.